Dr. Chandrika Bhatt. She's a consultant, pediatric immunology and rheumatology services at Rainbow Hospital, Bengaluru.
Establish a superiority that the DNB training is better than the MD training. It is to say which curriculum predisposes a student to which trajectory later on in life. And here we feel that DNB students are more likely to become better clinicians and MD students are more likely to take up academia later on in life. And this is simply because the way we are tested, the exam pattern that we have in MD and DNB also shapes how we perform later on in life. So just a few terms. We all know a clinician is someone who's actually adept at taking bedside decisions. They have to be quite hands-on. They have to have very good procedural skills. They have to have the confidence to take the history, analyze and come up with a plan in real time. Whereas an academician is someone who finds meaning in very structured thinking. They'll always ask why, document, publish, analyze it, conduct trials. So this is the way an academician naturally progresses. And what we know is that both of them are actually essential to the ecosystem of advancing pediatric care in children. So here the question is, which training system naturally pushes you in which direction? So let us take a few factors for that. First, colleges. And there are academic ecosystems, there are daily teaching rounds, morning reports, there are journal clubs, seminars, and you're encouraged to question, read, publish. And every faculty member has a certain designation, either an SR, assistant professor, associate professor, professor. So academic mentorship is something you're used to from your day one of residency in a MD training program. And also what happens is these MD training program centers are usually attached to government teaching hospitals which have very large volume of patient referrals. Now what happens is, although you see a large number of patients, you're more likely to see complex patients, whereas the routine day-to-day cases that you would see in a private clinic is actually missed out in a MD training program. So a lot of them are end-stage and very complex conditions. They are definitely very important because that is how you learn and progress in your field, but they are not the usual patients that you would see in real practice. And what about the teaching curriculum? Their case presentations, academic rounds, journal clubs, seminars and thesis discussions are encouraged. They are conducted quite regularly. So again, you have a very strong influence of academia on a day-to-day basis. Undergraduate teaching, because most of them are attached to government teaching hospitals, so you would have undergraduate students who rotate in pediatrics. So obviously you do take up undergraduate teaching quite routinely as well. Again, every case is discussed, dissected and debated on what has to be done. Obviously bedside teaching, bedside training also is a part of curriculum, but a lot of it is theoretical structured discussion as well. So what happens in the process is you're automatically designed to nurture reasoning, teaching and research. Now what happens in the DNB program is they are based out of private, corporate or mission hospitals. Here routine basis, but it is not as intense as an MD teaching program. The patient flow is quite heavy in high volume centers. The faculty, the consultant numbers are actually quite lesser compared to the number of patients who come to these centers, and the hierarchy is less intense. So here you would probably be more adept at learning routine pediatric cases like cough, cold, what you would see on a day-to-day basis, vaccination, and the follow-up, continuity of care, family communication, counseling forms a larger part of the training program than dealing always with high-end complex cases as what happens in MD teaching programs. So here residents obviously shoulder responsibility along with the consultants simply because the numbers are lesser, although this is very supervised as opposed to an MD teaching program where you probably have a free hand quite early on by the time you reach the end of first year or beginning of second year. So here you directly learn from practice in a DNP program as opposed to dealing with complex cases and academia in a MD teaching program. Now, how is the method of evaluation? Again, that determines how you actually undergo training, because at the end of the day, that is always there on your mind that at the end of 3 years, you have to give your exams. So how you train actually always is in preparation for your exit exam. So in MD examination, it's always university based, often in the same institution. You don't have to travel outside of your college to give your practical exam, and you have your internal examiners and a set of external examiners. The focus is always on theoretical depth, methodical presentation, and a very structured discussion is encouraged over here. And a lot of you would spend months training the art or perfecting the art of a long case viva, short case discussion and table viva and discussing your or defending your thesis. So what happens is the MD system actually rewards structured knowledge and academic fitness in the way they assess their students. As opposed to DNB examinations where it's a national standardized and an anonymous examination. So the students actually travel to different centers and they have a completely new set of examiners. No internal examiner is there as such. And they meet their examiners for the first time on the day of the examination. So every candidate is assessed, questioned, and the marking sheet, everything is quite uniform over here. So what happens in the process is a DNB student has to cultivate adaptability, they have to be calm under pressure, and they need to have strong bedside reasoning to be able to face their examiners. And we all know, we train for what we are tested on. So because the assessments are different, outcomes are different, and we perform the way we are tested. Because DNB assessments reward clinical objectivity and MD assessments reward analytical articulation. So obviously the testing is different, so your strengths are also going to be different at the end of the day. Now what is the influence of mentors? Our mentors always have a very big influence on what we decide to take up later on in life and how we are trained. In an MD setting, all the mentors are academicians. They're either researchers, professors, thesis guides, teachers of teachers. So that is what you're always seeing on a day-to-day basis. And they always see the faculty either conducting trials, writing protocols, presenting in conferences, publishing and teaching. And that is the reason why they absorb academia quite early on from the beginning itself. So what happens in the process, you would always look up to a mentor and think this is what I need to aspire to be. And as a result, research and being in academia becomes something that you look up to. Now what happens in a DNB setup is completely different. All the mentors are actually frontline clinicians, apart from a few of them who might be interested in academia, but simply because of the way a corporate hospital works, clinicians may not be able to take out enough time for research or academia. So here success measures are not by the number of publications but by outcome of patients. Did the child get discharged? Did the family get convinced? Were they counseled well enough? Did they understand the plan? And rounds usually end with decisions. There are not discussions that are usually done on a day-to-day basis. So obviously if you grow up watching your teachers always encouraging teaching, you become a teacher. Whereas if you watch your mentors always in clinical work doing something, you become a doer. So what happens after training? So this is the normal trajectory. Most MD graduates either stay within academia, they move from becoming a junior resident to senior resident, then an assistant professor, or they become teachers, researchers and start contributing to guidelines. And the other thing is also because you see a lot of complex cases in tertiary hospitals, you would probably end up super specializing. And these are the people who might later on end up in a private setup. And what happens with DNB graduates is they move usually into full-time clinical practice in either corporate hospitals, private clinics or high-volume service units. They become the hands of healthcare because they are the clinicians who ultimately keep the system alive with even the basic cases that have to be seen. Now there used to be some structural barriers which I now understand are not very rigid, in that DNB graduates used to face lower appointment into faculty positions. So they were made to channel their skills obviously where opportunity existed, and that was in clinical service rather than in a teaching hospital. Whereas MD graduates had a very clear academic pathway inside medical colleges. So although both were equally capable, it's just the system rewarded different choices. As a result, DNB trained students usually stuck to clinical practice and MD trained students usually went into teaching hospitals and academia. So what I'm saying is these two are complementary to each other. It's not a competition to say who's better than the other. And obviously medicine will thrive only when we have both clinicians and academicians working hand in hand. So without the DNP style clinicians, probably the knowledge would never reach the bedside. And without the MD style academician, bedside wisdom would never become evidence. So obviously I will be countered saying the DNP students are engaging in research now. They're presenting at conferences, writing research papers. But still, these are exceptions. The core engine of their training still prioritizes service and patient care. And I know I will be told that MD students do see a lot of patients and they're also clinicians. But again, there is a lot of hierarchy. You do have a lot of free hand, but most of the times it's not supervised. While in DNP settings, it is supervised training that happens quite early on. So it's just emphasis that MD students eventually move into academia, and DNB students become clinicians. So with this, I'll conclude saying if MDs probably write the textbooks, DNB's students fill the casebooks, and one shapes the next generations of doctors, and the other keeps the generation of children healthy. Thank you.
He doesn't require any introduction. He's Professor Pediatrics at Maulana Azad Medical College. So Dr. Anurag.
So good morning, friends, and first of all a huge thank you for the team NCP for organizing such a wonderful conference and having me on stage. Having said that, I'd like to thank my chairpersons, and one of them is a DNB I just saw on her CV, and she's in academic conference. Of course, Dr. Chandrika in the last slide accepted that the notion which she presented is wrong. That was the last slide she had. So my presentation. So now let us look at the legal and regulatory parity. So DNB started around 25 years ago, or slightly more than that. Once upon a time, DNB was a different ball game, and it has evolved over the last 25 years. The curriculum has improved. The academia in the DNB systems have improved. So now NMC has officially equated DNB qualifications with MD and MS teaching, academic promotion and clinical practice since 2019. The criteria for equivalence involve training in recognized institutions, fulfilling infrastructural and faculty norms. And the great thing about DNB is it has a centralized exit examination, which is conducted by National Board of Examination, and it has a standardized, impartial and rigorous assessment, often considered more challenging than university MD examination. So, MD exam, most of us have seen, क्या होता है? There is an exam definitely, yes, a theory is there and a practical is there, but it is all inside the institute. So it is more of an influence of the boss in the institute, what he wants. He knows everybody and he decides what happens in the exam. Whereas DNB exam, it is anonymous. The examiner does not know the student does not know the examiner. To the extent, the DNB exam is held in, North Indian students will have face a South Indian examiner, and South Indian student will face a North Indian examiner. I get invites कि सर आपको पूना में एग्जाम लेना है, आपको चेन्नई में जाके एग्जाम लेना है. Why? They want impartiality, they want anonymization, they want standardization. MD exam, it is all at the mercy of the 3 or 4 examiners, mainly the internal examiner. Other than that, regulatory documents confirm eligibility of DNBs for assistant professor and higher teaching roles subject to institutional policies. So, DNBs are now allowed to become senior residents and teaching faculties in MD institutes. Then, a lot of DNB institutes now have high volume multi-speciality hospitals, sometimes even better than a lot of medical colleges. Now, as Dr. Anurag Tomar was gone, he said that there are 30 medical colleges in Rajasthan and district hospitals have been converted to medical colleges. They are starting MD courses. So, do they have the faculty? Do they have the training manpower? Do they have the academic rigor? No. A lot of DNB institutes are better than them. So now DNB institutes have regular CMEs, journal clubs, morbidity and mortality meetings. And the great part is the online teaching. I have taken so many sessions for DNB students online. My colleague, he's done some amount of gastroenterology and he regularly takes sessions for DNB students. So they are getting expertise from across the country, and even international speakers come on stage, and it is being monitored and moderated by the NBE board. No such system exists for medical colleges which give MD degrees. So a medical college student is dependent on the faculty it has in the institute, not the faculty internationally. That is the usual phenomena. Whereas a DNB student is now customarily exposed to international level of faculty and is now getting a lot of academic input in his daily activities. So some DNB candidates may have greater clinical exposure. Yes, I agree with that, because there is a lot of personalized care in private institutes as compared to medical colleges, whereas there is less personalized care. But that means that in a DNB institute, student is not readily taking decisions directly. He is simply looking at the consultant taking decisions. Whereas in a MD institute like mine, a resident on floor is taking decisions, seeing patients, deciding and treating. So he has slightly better clinical exposure as compared to an MD. So maybe a MD student could be a better clinician if he is worked in a high volume institute, because he is deciding everything independently and seeing the result of his decisions. You understand? A DNB student is doing whatever his consultant is telling him. There is a child with fever, he will call up, sir, your patient you admitted has fever, what do I do? Okay, give paracetamol. Give paracetamol. Sir, fever is not responding, maybe give him brufen. You gave him brufen. Whereas in an MD institute, everything is decided by the PG or senior resident on floor. So the hokum that DNB is better clinically and MD is not that good does not stand true. Then NPE has a structured research protocol, a thesis protocol. How a MD thesis is examined, I will come to take exams, I will be presented 10 theses and I simply look at them and I have to sign them, I have no other option. I hardly will ever reject a thesis when I go for ND exam. DNB exam, I get thesis from across the country. I spend 1 hour, 2 hours on the thesis, go through it thoroughly and put my comments in, because I do not know the examiner, the student, nor the guide of the student. So I am impartial and I am putting in my comments. And I send back the thesis, and till date I have examined around 7500 theses of DNB and I have sent in lots of comments. Why? It is not that I want to discredit the guide or the student. It is so that the student learns what is research methodology and he corrects it and sends it back and it is accepted. So this process is much better in DNB. So saying that MD is having more academic exposure in thesis as compared to DNB also does not hold ground. Then the facilities available for doing thesis in an MD institute again depends on the type of institute. For an institute, say in a small district of Bhilwara or somewhere else, maybe a small district headquarter, there are hardly any facilities. How can you compare a DNB of Gangaram student hospital in Delhi with an MD student of Bhilwara? So it is venue dependent, the hospital dependent and faculty dependent. You cannot simply say no, DNBs are good clinicians and MDs will be good academicians. They are all dependent on the kind of institute they are working in and the kind of faculty mentorship they are having. So then, now numerous DNBs hold faculty positions. Madam is one example. I just came to know, as I said, we have a DNB faculty with us who's done extremely well in our medical college. In AIMS also there is a DNB faculty. So what is it dependent on? It is dependent on the aptitude of the student. What does he want to do in life? Does he want to go into research? Nobody can stop it. If he has decided that he wants to go into a medical college and do research, he is welcome. My senior resident presently is a DNB from Sanjay Gandhi Hospital in Delhi, and she is doing pretty well. Initially, again, I had the same fear, but she picked up in 15 days and she is doing better than a lot of MD students, academically and clinically. So, DNBs, of course, are into research. Madam has a huge number of publications because she has that academic orientation to do research. It is not that because she is a DNB, she will not be able to do research. She has that orientation, she wants to do it, she will do it. I am MD from a state medical college. I had 2 or 3 case reports, but I entered into another institute, Maulana Azad. There the culture is of doing research, and now I have 50 plus publications in international and national journals. Why? Because it is the institute, not because I was an MD from and not a DNB. That does not make a difference. It is me and my institute which makes a difference. Again, academic career progression for DNBs and MDs are linked to clinical expertise, as I said, research output. So what do you want to do? And institutional affiliation, as I said, and not degree type alone. So now, again, MDs go into practice. A large number of our MDs go into practice. Yes, they are good clinicians. It is their choice in life. They want to practice or they want to come into academics. They want to go into, it has nothing to do with your kind of degree. And academic and research opportunities exist but are not universally pursued or guaranteed for all MD holders, again, depending on the type of institute. And thus, there is a variability in academic rigor and clinical exposure dependent on the institute, the faculty and the clinician. Now, DNB institute, there is a faculty who resigns, in next 15 days you have a replacement. It's a private sector institute usually, and they can recruit very rapidly. Whereas institutes like us, recruitment takes 2 to 5 years. So we have a 30% shortage of faculty. With that shortage of faculty, can we give that academic rigor? Go to a state like, again I'll name it Rajasthan, wherein DNB, whenever there is medical inspection, the faculty is shunted from one place to the other. So can they give an academic output expected from an MD institute? No, because they have a chronic, huge faculty shortage. So this is again dependent on the system you are working in. And same goes with trials and audits and journal publications. These are all faculty driven. So I am doing clinical trials, I am publishing. My PG student thesis will get published. I do not want to publish, I get bored of it. His thesis will not be published because there is hardly much input from the student in publishing the thesis. It is usually done by me or my junior faculty who is interested in publishing. I lose the passion, the thesis will never get published. It has nothing to do with DNB or MD. So then resource variability. Some centers have a huge amount of resources, and I believe private corporate hospitals will have better resources as compared to a lot of state government hospitals. If they want to publish, they can easily publish and have good clinical material, because you require a good amount of research material, investigations. That again depends on the kind of institute, not the degree. Recruitment patterns, as I have discussed, now are dependent on research publications, teaching experience, clinical skills, rather than the name of degree. Therefore, residual preference for MD in some government and state institutions is fading, with NMC regulations pushing towards equality. So now when we go to take interviews, we don't bother about the degree. We ask him कि publication दिखाओ, अपना clinical acumen क्या है ये दिखाओ, what have you done till now. So that again is student dependent. So this perception bias that DNBs are good clinicians and MDs are good academicians should be discarded, and it has no meaning. This was maybe applicable 25 years ago when small hospitals here and there started DNB, when DNCBA was in inception phase. Now it has matured into a full-fledged program and is doing very well. So to conclude, both DNB and MD pathways produce competent clinicians and academicians capable of contributing to medical education, research and patient care. And career trajectory depends more on individual capacity, as I said, institutional support, as I have been pointing out, and regulatory environment. That is, what does the system want the student to do, or the institute to do, or the faculty to do, then on the name of degree alone. And there is a need for call for evidence-based recognition and recruitment practices aligned with NMC equivalence policies. And we believe in equal opportunity. Therefore, we should encourage mentoring and equal opportunity frameworks, ensuring holistic career development for all postgraduate medical students, other than instead of saying DNB versus MD. Thank you so much.
Chandrika, 30 seconds for rebuttal.
So, I would like to thank sir for his point of view. But I think the crux of this debate is what happens to most of the students in his own institute. He could come up with one, sir. The majority of them were MD. Now, I have done my MD and I work in a corporate hospital, and I can say there is a huge difference. So, the lack of staffing in MD colleges also means it's not just clinical work that's unsupervised, even academia might be unsupervised. So, I'm not sure these students are going to become good clinicians either, forget just academics alone. Now, in DNB setup, the complex cases, depending upon the center students are in, might be variable, but routine cases definitely they are exposed to a large extent, and it is supervised. And I think that is quite important, because you can't have an unsupervised first year giving out advice to patients as well. So in that sense, the quality of clinicians might be better, because by the time they come to third year, they are posted in ER and they do take independent decisions. So it's not that they have absolutely no liberty at all. So I think it's just the orientation to say most of the MD students are inclined to taking up academia simply because of the environment they are in. Whereas in corporate hospitals, definitely if a student is in a place like Gangaram where they are exposed to research, I'm sure a DNB student would become an academician. But again, there are few centers who are like that. Most of the DNB centers cater to the bulk of clinical practice than academia.
Another 30 seconds for rebuttal.
I don't think 30 seconds are needed anymore. And yes, this was a debate 20 years ago, but now it does not hold true because similar situations exist in MD institutes, whereas DNB is being done in government institutes like Baba Saheb Ambedkar, Hindu Rao Hospital. These are government institutes, they are conducting DNB courses. So this debate no more holds true. It is dependent on the student what he wants to do in life, and of course the kind of institute he is working in.
So to conclude, I would say, Dr. Pin.
Institute, it is considered equivalent to MD, or senior residency if you have done in a teaching institute, it is considered equivalent. And I believe in UPSC interviews, the experts who sit there look at your yes, one exception. देखो मैंने आपको फुल फॉर्म नहीं बताया DNB का। DNB का फुल फॉर्म था डॉक्टरों के नालायक बच्चे जिनको डिग्री दिलानी होती थी तो वो करते थे DNB आज से 25 साल पहले। That has changed.
Sir, it will take next 25 years to change because you have different perceptions today. Anurag sir, you have different perceptions.
I think the debate is becoming hotter, so I need to conclude. So what we all know is that the DNB training is robust, and as far as the bias towards DNB was there in interviews is fading. I would not say it has gone away. It is fading day by day, and people are taking them more on merit rather than by the degree they have done. And ultimately, what a person takes up trajectory, the medico depends upon his own, I think, inner calling, his alignment, and the opportunities and the environment he gets. So with this, we conclude. Thank you both the speakers.
The words which he said, I just want to say that it depends